Thank you everyone for joining us today. We'll begin in just a few minutes to allow people to enter the room before we get started. Welcome everyone. Thank you for joining us today for the event titled Time to Refocus, Working Together to Support People Living with HIV and NCDs, co-hosted by American College of Cardiology, Viatris, and NCD Alliance. I'm Marie, and I will be your technical facilitator today. For assistance, please use the chat function to message anyone with the title Technical Facilitator in their name. Before we get started, I have a few technical notes to explain. If you would like to contribute a perspective, idea, or thought, please use the chat function. If you would like to ask a question, please use the Q&A button. You can find both of these features at the bottom of your Zoom window. Please note that this session will be recorded for documentation purposes. For those of you just joining us, welcome and thank you for attending the event today. I will now pass the floor to Dr. Emily Wong. Dr. Emily Wong, the floor is now yours.
Hello, everyone. Welcome to today's event. Time to Refocus, Working Together to Support People Living with HIV and Non-Communicable Diseases, which is co-hosted by the American College of Cardiology, Viatris, and the Non-Communicable Disease Alliance. Thank you so much for the organizers for inviting me to moderate. I'm Emily Wong. I'm an assistant professor at the University of Alabama, Birmingham, and a resident member of the faculty at the Africa Health Research Institute in KwaZulu-Natal. The topic that we're discussing today, which is the ambitious goal of integrating non-communicable disease and HIV care to benefit individuals and communities affected by the HIV pandemic, is very near and dear to my heart. Just before the beginning of the COVID-19 pandemic in early 2020, we completed a population-based multi-disease health survey called Vukuzazi in a rural area in the Mpumalanga district in KwaZulu-Natal. We found through mobile health clinics that HIV, which is one of the most, we in KwaZulu-Natal are in one of the most intensely infected areas of the world, with 60% of women in my age group infected with the virus. And yet we found that control of that disease was optimal, meaning suppressed viral load in greater than 80% of people with HIV. And yet the two non-communicable diseases that we screened for, which were hypertension and diabetes, which were present in respectively just under 1/4 and 8% of people in our population, were actually very less well controlled, with just under half of the people with hypertension and less than 10% of the people with diabetes having optimally controlled disease. So these findings, which keeping in mind were collected before the advent of COVID-19, which has brought its own significant challenges to all of these diseases, really highlight today the challenges, but also what we need to try to achieve as a community as we enter into today's exciting discussion. So with that, it's my pleasure to introduce Professor Liesl Zolke. Professor Zolke is a pediatric cardiologist in the Department of Pediatric Cardiology at the Red Cross Children's Hospital, and she is also an NCD Alliance board member. And I'll hand over to Professor Zolke now to provide opening remarks.
Thank you very much, Emily, and thank you on behalf of the NCD Alliance for moderating this session. It's my pleasure to share with you some opening remarks on behalf of the NCD Alliance. I'd like to thank everybody watching and everybody who's going to be participating in this webinar for joining us in what I'm sure will be a really interactive and thought-provoking discussion on how we can make integration for people living with HIV and NCDs a reality. A special thank you to our co-hosts for this event, Viatris and the American College of Cardiology. Today, we will focus on the provision of integrated services, as well as innovative healthcare solutions for NCD care. We plan to reimagine health service delivery by exploring opportunities for integration of NCD prevention and care with existing global health priority programs, and together to consider opportunities for supporting those living with NCDs and HIV. But as Emily mentioned, we can't talk about integration without mentioning the seismic impact of the COVID-19 pandemic. It has shown us that health systems globally are inequitable, inefficient, vulnerable, and underfunded. Most of the millions of people to date who have lost their lives to or become seriously ill with COVID-19 had underlying health conditions, most commonly hypertension, cardiovascular disease, chronic kidney disease, and diabetes. COVID-19 has shaken the foundations of health systems and economies everywhere. People living with NCDs have been at the epicenter of this crisis in all countries, and specifically low and middle income countries. If we want to build back better and more equitably from this pandemic, then we have to invest in a more integrative approach to ensure that our health systems are fairer and fit for the future. The global health and development communities have for too long overlooked NCDs, dismissed NCD care as being too costly, and this has resulted in deeply entrenched silos in global health programs and funding. This is the context for a new NCD Alliance policy report, From Silos to Synergies, commissioned to the George Institute of Global Health and supported by the Hemsley Charitable Trust and available on our website for dissemination. This program and this report reminds us that people don't live in silos. People living with HIV or TB are more susceptible to many NCDs. In South Africa, my country, half of people living with HIV are also seeking care for one or more NCD. People living with HIV are twice as much more likely to develop heart disease, and a third of them have hypertension. There are great examples of how integrating HIV and NCD care into existing health programs can benefit the community. In Western Kenya, in a program that started in 2010, leveraging the AMPATH HIV community-based model of care has provided diabetes screening to those aged 18 years and older. In June this year, world leaders confirmed the need to provide more integrated services to include NCDs. There's been a groundbreaking commitment at the United Nations to ensure that 90% of people living with and at risk for HIV can access NCD and mental health care by 2025. We know that when NCD services are integrated, there are far-reaching benefits, including increases in access to specialist care for underserved groups, better detection and diagnosis of NCDs, retention in care and effectiveness in both HIV and the NCD care streams, and most important, reduction in the disease burden with resultant, more cost-effective health systems and services. Over 1/4 of the world's population live with one or more NCD, putting them now at even greater risk for COVID-19. We stand at a critical juncture to change the siloed approach. Instead, we need to integrate and strengthen existing health services and systems to provide sustainable, person-centered care for everyone. So with these short comments, I'm going to now hand back to you, Emily, and I personally look forward to hearing from our keynote speakers and the rest of our panelists today. Thank you so much.
Thank you, Liesl, for those very stimulating remarks, especially the call for equitable comeback from COVID-19. It is now my pleasure to introduce our first keynote speaker, Dr. Ren Minghui from the World Health Organization. He is the Assistant Director General responsible for the universal healthcare coverage, communicable and non-communicable diseases at the World Health Organization in Switzerland. Dr. Minghui.
Thank you, Emily. Excellencies, colleagues, and friends. We meet today to discuss integration and solidarity, not only as principles, but as a way of working that are the expectation and becoming the norm. Be responsible for communicable and non-communicable diseases at WHO. I have witnessed firsthand how WHO guidelines drive change, starting from the use of antiretroviral drugs for treating and preventing HIV infection. Clinical algorithms in HIV has been very important in the routine service delivery at the primary healthcare level and has assistance with logistical improvements in supply chain systems, bulk procurement, and other medicines-related intervention. Built on this success, WHO launched new guidelines last month on initiating hypertension treatment in more than 1 billion adults. We anticipate a similar response to the hypertension guidelines as those for HIV. Since I started in 2017, it has been my priority to promote inclusion of NCD prevention and control within the programs for the HIV/AIDS, tuberculosis, mental health, and sexually reproductive health and maternal and child health care programs, especially at the primary health care level. My priority builds on the commitment made by the heads of state and the government in the United Nations Political Declaration on NCD in 2011 to also build synergies between these areas and NCD programs. In 2019, the heads of state and government went further to commit to cover 1 billion additional people with the integrated health services to meet their health needs throughout the life course. This resulted in a strategic shift in public health to identify shared programmatic priority to work together across diseases through the person-centered approach. Integration in the people-centered approach through the primary healthcare delivery is not optional. Perhaps one image tells tales of our time. One woman living with HIV has a higher risk of cervical cancer. She had a higher risk of NCD. What a missed opportunity to manage her HIV, but to ignore her other health needs. Excellencies, I'm here to sound alarm. The world must wake up. We face the greatest cascade of crises in our lifetimes. The COVID-19 pandemic has shaken our health systems. Services are disrupted. A surge of mistrust and misinformation is polarizing people and society. Science is under assault. Solidarity is missing in action just when we need it most. The need for integration and solidarity become more urgent. The link between the communicable and non-communicable diseases has become more obvious. Many of the people suffering modalities and mobilities from COVID-19 has also been those living with NCD and HIV. Gaps in NCD and HIV services has become more obvious and more severe. At the same time, epidemic of non-communicable diseases continue to grow. Today, more than 1 in 3 lives lost to heart attack, stroke, and diabetes or asthma occurs before the age of 70 and are largely preventable, yet these conditions remain overwhelmingly neglected. The bottom line is that over the past 20 years, the burden of NCD has changed the world. They have become the leading cause of death in most of the countries, resulting in 200 million premature deaths among women and men aged between 30 and 70. The majority of them living in low and middle income countries. During the next 10 years, another 150 million people will die from NCD between the ages of 30 and 70. Most of these premature deaths can be avoidable or delayed. At the global level, 7 of 10 leading causes of death are now from NCDs. In December 2020, the United Nations General Assembly noted with concern that the people living with NCD are more susceptible to the risk of developing severe COVID-19 symptoms and are among the most affected by the pandemic. Alarm bells are ringing at WHO at the February page as well. In May 2021, the World Health Assembly called on action taken to respond to and recover from the pandemic must include urgent action to close the NCD divide that is fast becoming the new face of inequality. We at WHO have shifted our working. First, integration is the foundations of WHO programs on universal health coverage. The UHC program at WHO is means by which diseases programs communities work together towards a shared goal. Second, WHO's primary healthcare programs is promoting coherent national policies for people-centered health services, noting that the UHC can only be achieved if services are delivered in an integrated manner. Third, we have good examples of successful programmatic integration. One of the most striking is WHO's global strategy for the elimination of cervical cancer as a public health problem, which was endorsed by all member states in November 2020. The evidence is very clear. Addressing cervical cancer is an integral part of HIV response. WHO is providing governments with the guidelines for screening and treatment. This includes specific recommendation for the women with HIV to receive the early screening at the higher frequency. We have started countries level implementation, offering cervical cancer screening as a part of HIV services and leveraging existing platforms. We are using the experience and lessons learned in decentralizing enrollment into care, retention, and longitudinal follow-up of people living with HIV to support prevention and control for NCD. More broadly, an NCD and HIV agenda, we have convened global experts to establish priority. We have expanded the scope of NCD programs and management in HIV programs, including mental health conditions, chronic nervous system diseases, and cardiovascular diseases. Integrated services improve the access and break down the barriers of discrimination associated with the vertical approach. The COVID-19 response and recovery are an opportunity for us to enhance integration and achieve universal health coverage. Excellencies, humanity has shown that we are capable of doing good things when we work together, building on our legacies of success. The problems and the challenges of today can be solved. I'm looking forward to opening these new chapters together when the integrations drive us towards universal health coverage and to the health for all people everywhere. With that, I thank you very much, Emily.
Thank you very much for those stirring remarks. I very much have witnessed the world's response to the HIV epidemic with the leadership of WHO guidelines and look forward to those coming guidelines from the non-communicable diseases. This will be very helpful for the world, for the global health community. Next, we'd like to welcome Dr. Jonathan Chawanda, who is our second keynote speaker from the Department of Health in Malawi. Dr. Chawanda is the head of non-communicable diseases and mental health in the Ministry of Health. Over to you, Dr. Chawanda.
Hello, everyone. I'll take you specific to Malawi in terms of what I've been doing in integrating HIV and NCD services with specific examples, and also what has been the challenges in the time of COVID-19 pandemic, and how do we envisage moving forward from here. So this is Malawi is a country that is in southern part of Africa with 19 million people, and of course life expectancy and HIV prevalence is at 8.9% among the adults from 15 to 49 age band, and over 1.1 million are HIV positive, and this is bringing us to the burden of the HIV in Malawi. And in as far as other non-communicable diseases are concerned in Malawi, according to STEP survey, a recent STEP survey has shown that hypertension prevalence in Malawi is at 16%, overweight at 22%, diabetes at 2% as well. And that the rationale why we're bringing in these two burdens, like the HIV burden and also other non-communicable diseases burden, is actually to have, that HIV and ART are risk factors for quite common NCDs because they share common risk factors. And among HIV population, for example, hypertension prevalence ranges from 24 to 46%, and about 15% of deaths that occur among HIV people are attributed to cardiovascular diseases. And of course, in overall, non-communicable diseases contribute to 32% of the deaths in the country. And it also contributes about 40% of disability adjusted life years. So in terms of healthcare delivery in Malawi, is free at the point of access since 2004, and we follow up essential health package, which has got a group of conditions that are common in the country, and that people are getting this service free at their point of service. And also we have extended to introduce what we call service level agreement, which is free access to those private institutions, particularly affiliated to the religious health facilities, where the government also pays those facilities whenever a patient goes to those facilities seeking care. So our health strategic plan, and of course, the vision of the country is to move towards complete universal health coverage, which is what our strategic plan is actually emphasizing. And of course, NCDs and HIV are among those in the essential health package, and that is being provided. So starting from 2004, the country, Malawi, has been rolling out free ARTs. And Malawi is a country that has a significant registered progress in was the first country to roll out prevention of mother-to-child transmission of HIV/AIDS, and also we have significantly registered progress in terms of coverage of 90 targets of 2020, and that this is a well-established clinics. So Malawi has got well-established ART clinics in the country, spanning over 752 sites. And what we're doing is actually to ride on the back of this quite established clinics to introduce other NCD services. For example, screening for cervical cancer, and also making sure that we do the screening for hypertension, diabetes, and other diseases. So we do this in partnership with the different partners like Public Health, Partners in Hope, Lighthouse, and also other stakeholders. So one very good example is the integrated chronic care clinics that are being provided by partners in health in Neno, and of course has been having registered success because of increase in number of attendance, and also reduced rate of default rates. So basically, to have an integrated NCD service, you would need to have multi-sector departments, like for example, all the government departments that are involved in this care to come and have deliberate efforts towards having regular meetings on how best to integrate. And that also would need different civil society organizations to bring in awareness and demand creation. So that also would need that different stakeholders should do the more trainings, particularly training healthcare providers on how to provide service, both HIV and other NCDs within one roof. So this emphasizes the multi-sectoral approach to things. And of course, we know that with HIV and with COVID-19 has been a challenge, but we are doing better. And the importance has been that if you're doing integrated services, it means reduce our hospital visits, it is convenient to patients, and also avoid double reporting for data, easy planning, and also minimize stigma, particularly for those that have HIV. So I think a few challenges are in, but otherwise, inadequate health providers, loss of follow-up. These are the routine examples of the challenges that can be really looked up and working towards improving that. Thank you very much.
Thank you so much. It's wonderful to hear what is being planned and enacted in Malawi and how the multi-stakeholder approach is really beginning to show some positive direction. So with those very inspiring two keynotes, it's now time for us to move on to our panel discussion. We have a very exciting lineup of 5 panelists who represent those different stakeholder sectors. And our first panelist today is Ms. Charity Muturi. Ms. Muturi has the experience of living with a non-communicable disease and supporting family members who have multiple non-communicable diseases. She is also on the advisory committee for the Non-Communicable Alliance initiative, Our Views, Our Voices. So Ms. Muturi, as a representative of the community and of the patient populations, we would really like to understand what your experience has been like navigating health systems in Kenya, and what have been your challenges, and if you're aware of any strategies that have been proven successful to provide more integrated care for HIV and non-communicable diseases. Thank you. Floor is over to you.
Okay. Thank you so much. Yes, my name is Charity from Kenya. I have lived experience with a mental health condition and care for my parents who have 6 non-communicable diseases. As persons with mental health conditions, we experience stigma as bewitched, demon-possessed, and discriminated in our access to rights to inclusion, justice, voting, leadership, family, and even property ownership. We receive only 0.01% for mental health and only 3% for NCDs in the Kenya health budget. We have high out-of-pocket expenditure with no social protection, which leads to financial hardship. People with HIV are living longer with ARV treatment, but some are dying of NCDs. When COVID hit, we had survival and healthcare crisis in our peer support groups. We struggled with external fundraising and fundraise within our members, supporting 30 members and enhanced virtual support. As people living with NCDs, we were very affected by clinic closures, disruption of essential medical supplies, movement to specialist clinics without alternatives in primary healthcare. COVID restrictions, stigma, and economic hardship resulted in fear, heightened vulnerabilities, and limited access to healthcare for people living with HIV. Last month, I lost 4 relatives, all recorded as COVID deaths, yet diabetes, hypertension, and cancer worsened their health outcomes. NCD, disease severity, and deaths are mostly unreported. Last year, we achieved inclusion in the National Task Force on Mental Health in Kenya through a rights-based media advocacy approach from the NCD Alliance, Our Views, Our Voices advocacy training. Since then, we have joined 6 national mental health committees and hospital boards. As NCD Alliance Kenya, we achieved inclusion in the Ministry of Health NCD COVID subcommittee, where we reported our challenges every week to the relevant government departments. This year, we participated in the Kenya NCD strategic plan. Our efforts, though, to engage the UHC Committee for Inclusion has not borne fruits yet. Yesterday, our National Hospital Insurance Fund, which is our UHC vehicle proposed benefit reductions that will affect especially kidney patients, and they are not open to discussion. They haven't paid our National Psychiatric Facility claims for over 6 years, and these are injustices that we are concerned about. As 50 persons living with NCDs globally, we engaged WHO on inclusion, and they published the meaningful involvement of people living with NCDs, nothing for us without us. The link is being shared in the chat. In terms of proven strategies, the NCD Alliance has adopted prioritization of lived experience and global endorsement models from disability and people living with HIV JIPA principles. Our National AIDS Control Council have integrated diabetes, hypertension management, and cervical cancer screening. And AMPAT, mentioned by another panelist, integrated phone-based self-monitoring of blood glucose. The NCD Alliance Global Agenda for Resilience and Recovery focuses on governance, prevention, and health system strengthening, including community-based primary healthcare focus and rethinking investments, including the local production of NCD essential medicines. So what is our call to action? Let us mobilize funding and partnerships to integrate NCDs and mental health prevention, screening, and management in HIV care, and integrate wider coverage of NCDs into traditional mainstream NCD management. Prioritize integration of community-based primary health services within the local context-specific approaches as we build back resilient, affordable UHC and Sustainable Development Goal 3. Provide equitable financing for HIV and NCD management and inclusion in all UHC benefit packages globally. We call upon you as multilaterals, as government, as CSO, as private sector, to endorse the Global Charter of Meaningful Involvement of Persons Living with NCDs. The link is being shared in the chat. Lastly, when health and social protection systems fail, we pay with our lives. So we advocate for the mandatory leadership inclusion of persons with communicable and non-communicable diseases in all health policy design and execution, including COVID-19 response, NCD integration, and UHC at global, regional, and national levels. Nothing for us without us. Thank you.
Ms. Muturi, thank you very much for that stirring call and for reminding us of the cost of not integrating care and how far too often those costs then devolve onto the patients themselves, which is entirely unacceptable and doesn't lead to good outcomes. So with that, I'd like to introduce our next speaker, who is Dr. Robert Ferris. Dr. Ferris is the Chief of the Division of Prevention, Care, and Treatment at the USAID's Office of HIV/AIDS and Global Health. Dr. Ferris, can you share some of your reflections on the integration of NCD and HIV services following the 2021 political declaration on HIV and AIDS? What might this mean for the future of parallel funding mechanisms?
Dr. Wong, thank you very much. And I just want to thank, on behalf of USAID, the hosts, the panelists, and particularly the participants in today's Time to Refocus. It's wonderful to have the opportunity to speak today. As you know, the U.S. Agency for International Development is proud to be a major U.S. government agency implementing the U.S. President's Emergency Plan for AIDS Relief, PEPFAR. Through PEPFAR, the U.S. government has invested over $85 billion in the global HIV/AIDS response, the largest commitment by any nation to address a signal disease in history. PEPFAR programming supports 300,000 healthcare workers, including community healthcare workers, over 3,000 laboratories, and 70,000 healthcare sites. Notably, PEPFAR investments have saved over 20 million lives, prevented millions of HIV infections, and have accelerated progress towards controlling the global HIV epidemic. These investments have also led to increased global capacity in health, particularly pandemic preparedness and response. We've seen it already help countries respond to Ebola, H1N1, and even the COVID-19 pandemic that we're all facing now. Sustaining HIV epidemic control requires scaling efficient and simplified service delivery approaches to both direct resources to individuals challenged to maintain viral suppression, as well as to provide consistent prevention measures, sustaining epidemic control. The sustained phase of HIV response demands host country-led operations and, which I think is most important to your question, integration into host country health systems. And these are both hallmarks of what USAID's programs have done and will continue to move towards. USAID ID will continue to employ whole of agency assets and efficient, measured, and simplified programmatic approaches to ensure resilient and country-led responses. Assets include comprehensive health programming, including malaria, tuberculosis, reproductive health, family planning, maternal and child health, nutrition, and global health security, as well as a vibrant and established education, economic growth, democracy and governance, humanitarian assistance, and human rights portfolio. Combined, these assets will ensure long-term sustainability and success in the decades-long fight to control HIV, as well as other diseases. The PEPFAR program promotes person-centered service delivery for populations most in need. And it's really important to listen to clients of services. And as our previous speaker mentioned, nothing without our clients and the services that they need. This can extend way beyond HIV. Examples include models of differentiated service delivery, especially multi-month dispensing, which we found very important for delivery of HIV commodities, particularly antiretrovirals, but it can also be used to deliver tuberculosis medications, hypertensive medications, medications for diabetes as well. Continuity of care has been incredibly important in COVID-19 at health facilities. And again, differentiated service delivery models have allowed patients to continue to access care in a particularly struggling time. Supply chains established to support HIV programming in 43 countries have been instrumental in executing the response to the COVID-19 pandemic, but can also be harnessed for using and addressing other diseases. PEPFAR is in the process of developing a new strategy, a Vision 2025. We'll be able to greatly inform a coordinated response with other strategies that are being put together. And I just wanted to mention that there is still plenty of time to comment on the PEPFAR strategy. And feel free, particularly making comments on non-communicable diseases. You can find that on the pepfar.gov site and the appropriate places to provide your public comment. So there's only a few seconds left. So I think I'll end here and look forward to the further discussion with the rest of my panelists and participants later in today's meeting. Thank you very much.
Thank you very much, Dr. Harris. And thank you for highlighting the PEPFAR program, which, as we all know, has been a really remarkable success in the HIV epidemic. But as we are highlighting here, we need to move beyond such a vertical program and begin to figure out how it integrates with the other major causes of morbidity and mortality around the world. I would next like to introduce Dr. Lobna Salem, who is one of our co-hosts, who represents one of our co-hosts for this event, Viatris. Dr. Salem is the Regional Chief Medical Officer for developed markets in Japan, Australia, and New Zealand for Viatris. And it would be wonderful to hear you speak to us about how the private sector can contribute to operationalizing integration of HIV and non-communicable disease care, and what you see as some opportunities for engagement. Thank you.
Thank you so much. And I'm delighted to be here today among all of you and such an esteemed panel and speakers. So I know I have 5 minutes, so I'll try to be quick. So I just want to, I'm the Regional Chief Medical Officer for North America, Europe, Australia, and New Zealand, and Japan for Viatris. Viatris actually was formed in November 2020 through an integration of the Upjohn division of Pfizer and Mylan. So it's a very, I would say it's a very timely integration as we're speaking about integration between communicable and non-communicable diseases. We brought together in Viatris 2 unique portfolios, combining the NCD focus of Upjohn and the infectious disease and HIV heritage of Mylan. So I think, as I said, it's a timely integration. We have a mission at Viatris. We see healthcare not as it is, but as it should be. We are uniquely positioned as an organization by our comprehensive portfolio of high quality products and our global footprints. We operate in more than 165 countries across the globe to be a source of stability in the evolving healthcare needs, and definitely the evolution of both communicable and non-communicable disease is just an example of that. We empower people, Viatris empowers people worldwide to live healthier at every stage of life, and we do this via, it's called Viatris, so it's via 3 pillars. We have access, leadership, and partnership. Let me very quickly jump into some of the integration domains that we're talking about here, and I'm hoping the time would allow me. The first domain that was very important, and I like very much the term solidarity, the solidarity and alignment of purpose. I think despite it can be appear simple, but the link between communicable and non-communicable disease only recently has been spoken about. And I just want to say that HIV has been, despite some delays in the targets, but it has been a success story compared to NCDs. And as we are rallying the healthcare community behind NCDs or with NCDs, we really put HIV as a good example. But as you see here is that we cannot be in silos, because as HIV trying to hit the milestones, the NCD kind of burden kind of drags it down. So it's very important to kind of look into all these disease burden holistically. Also, we have a very, I would say, current example on COVID-19, where we have the most people, people living with NCDs were the most vulnerable and to contract COVID and also suffer from its sometimes deadly consequences. What did Viatris do as a private sector example? I'm sure there's a lot of very good examples, but as I'm speaking on behalf of Viatris, we have currently a research paper to look together with NCD Alliance and ACC on looking into the links and the models that we can leverage from an HIV, kind of efforts to leverage the NCD, highlighting the link and the close linkages between non-communicable disease and HIV. We will have, hopefully by the end of this year, we're going to have this paper published. And so we're hoping to get very useful findings out of it. That augments a lot of literature that's already out there. Also, we have done back to the nothing for us without us. We did a patient survey for 2,500 patients, people living with NCDs, on the impact of COVID on treatment, kind of treatment access, on mental health, and it's mainly in Europe and the United States of America, but also we have done a similar survey in emerging markets in partnership with other patient organizations. So this is, kind of how we integrate and how we really look into integration, the voice of the patient, and also solidarity with patients, organizations, and civil society. The other domain is the disease management. And again, we do understand the holistic approach for both communicable and non-communicable disease, but we do understand that we need to kind of attack diseases head on. So we do have high quality products for Viatris. We have 40%, we provide 40% of HIV medications globally, and 60% of the pediatric population's medication for HIV comes from Viatris. Also, we have the unique capabilities in the NCD portfolio for products that actually shape the guidelines. Integration of care, and this is my last point, integration between primary and tertiary care. It's very important that we understand the role of this integration, not only on effective management of the burden, but also on the drainage from economic perspective. We created the first ever NCD Academy platform, which is a digital platform for healthcare workers. And with the understanding that NCD is a holistic burden, we also included COVID chapters, social determinants of health in it to ensure equity of access. Also, we have, included also, we're hopeful to have a chapter on HIV as well as NCD once we have the results of the policy paper. To sum up, there's no one size fits all. I think with our unique capabilities, our global footprint operating in more than 165 countries, we are able to really understand the nuance by region. The problem can be known for everybody, but the reasons for that, it is very specific, it's very personal, and with the local knowledge that private sectors have in the countries, we can definitely achieve solutions together. Thank you so much.
Thank you very much, Dr. Saleh. Before introducing the next panelist, I would just like to appeal to the audience to remind you that coming up at the end of this panel, we will be having some question and answer. So please, if you can put your questions and answers into the question and answer section, then we will be able to have a very interesting conversation during that part of this presentation. So next, I'd like to welcome Dr. Dipti Itchapuria. Dr. Itchapuria is the president of the American College of Cardiology, which is another co-host for this event. So Dr. Itchapuria, can you speak to us about how the American College of Cardiology is working to promote an integrated approach to NCD care? Over to you.
Thank you so much, Dr. Wong. It's a pleasure for me to be here. On behalf of the American College of Cardiology, its members and staff, I want to thank the NCD Alliance and Viatris for co-hosting this event and having us be part of the program. I want to share ACC's integrated approach to non-communicable disease care and our global mission. ACC is the world's largest organization of cardiovascular professionals, representing over 54,000 members spanning the entire cardiovascular care team across 150 plus countries. Our comprehensive network of US and international chapters, coupled with our 20 plus member sections, enables us to drive real, on-the-ground change and positions us out front in advancing solutions for global heart health. Currently, we have been focused on our strategic goal to advance quality, equity, and value of cardiovascular care. The fact that cardiovascular disease is the leading cause of death globally, taking almost 18 million lives each year, that's 32% of deaths worldwide, really adds importance to our work of combating cardiovascular disease. The COVID pandemic has only created a greater urgency and challenge to tackle cardiovascular disease. The pandemic puts into focus the intersection between disease burdens and the intersections that are important to build sustainable health systems. Today, we're focused on the important intersection between HIV, AIDS, and NCDs. As a cardiologist, I know that the inflammatory response associated with HIV and AIDS puts individuals at greater risk of dying from cardiovascular disease. At the ACC, we're actively involved in many similar efforts, including the intersection of cardiometabolic, cardiorenal, cardio-oncology, cardio-obstetrics, and many other important areas. We believe this type of approach is crucial to optimally promote cardiovascular disease prevention and long-term target chronic disease development. We know that identifying those at highest risk for cardiovascular disease and ensuring that they receive appropriate treatment can prevent premature deaths. As we think about these intersections, we also have to think about the healthcare workforce, how we deliver care and how we communicate. We know there are far too few cardiologists to manage the epidemic of cardiovascular disease worldwide. This means we have to look towards capacity building. It means building coordinated systems of care where every member of the healthcare team is delivering the highest possible degree of care within their training. The reality is that primary care clinicians are the key to combating infectious and non-communicable disease, and we need to train them within and across these diseases. I'm really going to come back to this and tell you about an ACC program that just does this. But as we think about tackling cardiovascular disease, we also have to think about building systems of care, looking at the intersections between sectors and how NGOs, private sector, academia, and others need to pull together to drive novel solutions that build a durable healthcare system in a post-pandemic world. In this process, we have felt strongly about the digital transformation of healthcare. At the ACC, we have a robust innovation program that has looked at the intersection of technology and healthcare. From a clinical perspective, this has largely been divided into 3 buckets: virtual care, remote patient monitoring, and AI or artificial intelligence-driven care. Interestingly, the pandemic propelled us forward in the virtual care arena with the utilization of telehealth. We believe that technology and digital transformation of healthcare offers the single greatest opportunity to transform the future of healthcare delivery in both developed and developing countries. If we remain laser focused on building digital platforms for delivering high quality, low cost, personalized care, we can build a healthcare future that enhances, not exacerbates, our ability to provide equitable care to patients regardless of their geography or their income status. And I want to pause for a second and briefly mention health equity and the healthcare disparities, which have certainly come to the forefront during the pandemic. At the ACC, we launched a presidential task force on health equity, and I was fortunate to chair this last year as we developed a strategic plan to permeate the culture of health equity to all aspects of our strategic plan and all of the work of the college. I want to go on to the program I was telling you about, which is the NCD Academy, which is an innovative free education platform built for primary care community in low and middle income countries. The NCD Academy is the work of collaboration with industry, the World Heart Federation, and the NCD Alliance. And this is on-ground education where it's needed the most. It uses an e-learning technology to equip healthcare providers with high-quality continuing education available anytime. And it includes content across 5 major NCDs: cardiovascular disease, cancer, respiratory, diabetes, and our newest course, which is mental health, found to be critical during the pandemic. And we have to start bridging the content into infectious disease state with our COVID module. All content is developed through an interdisciplinary partnership. And really the next step for the program is to build content about the importance of managing the intersections between these diseases. I think today's session highlights a crucial opportunity for us to expand that focus by educating clinicians around the intersection of HIV, AIDS, and NCDs. And really in less than a year, we've had over 13,000 primary care physicians in low and middle income countries that have completed this NCD Academy course, which is amazing success in the midst of a pandemic. Really, we're excited. There are several other projects that I can share with you, including our Global Heart Attack Treatment Initiative, which has really helped improve heart attack outcomes in low and middle income countries. We've done this program in 2,000 patients at 18 medical centers in 13 countries on 4 continents. I certainly don't have time to go into details, but the CADI program was presented at our scientific session. But really, we're excited about the opportunities that lie ahead to make real change around NCDs and are proud of the work that has already been done and the relationships that we've built. We look forward to continuing to learn, lead, and grow into the future to remain out front as we work to improve global heart health. I can't say it enough. We're stronger because of the work we do together. And I'd like to thank our partners at the NCD Alliance and Viatris for co-hosting this session and for their partnership on the NCD Academy. And I'm looking forward to the rest of our discussion today. Thank you very much.
Thank you very much, Dr. Ichaporia. And thanks for highlighting those very exciting and very useful innovations that just as on a personal note, we have as a follow-on from the project that I described, we have started providing telephonic tobacco cessation counseling in our rural district, and we really benefited. We had one of our primary health care nurses take an online training, which was able to then give her the skills to do an entirely telehealth intervention. So those tools can be really useful even in resource limited settings, although of course, internet access is always an ongoing challenge. And finally, we'll hand over to Dr. Gang Sun. Dr. Sun is a senior advisor at UNAIDS, and he will share some of the ways that UNAIDS and their partners are promoting a more integrated approach to care for people living with NCDs and HIV. Thank you.
Many thanks, Emily, and thanks to the co-host for inviting UNAIDS to be part of this very important discussion. Probably, I mean, from UNAIDS and largely the AIDS community could offer probably 3 approaches to suggest that to have a better HIV and NCD integration. One would be the people-centered approach. Second would be applying inequality lens. And the third, to make the measurement work, so the measurement for result. On the first part, of course, the putting people at the center helps to align our system design, bring down silos, and prepare possibly the best services, not around what service providers would want to offer, but that would be what the people actually would need. So everyone has a different identity, and those kind of different identities are interact at the same time. So as previous panelists already talked about, that HIV has been proved to associate with the cardiovascular diseases. I would also add on that HIV positive women are up to 5 times more likely to develop cervical cancer. That's also a case. So UNAIDS and partners are advocating and supporting the people-centered approach with the hands-on support to address a few HIV comorbidities, which are including TB, hepatitis, sexual reproductive health, the illness, mental health, and cervical cancer. And here, when we talk about people-centered approach, we cannot away from people, right? And here we consider that civil society and community probably would be the closest linking with the people and they represent the people's voice and people's need. Let's raise an example on how we work on the cervical cancer along with the many partners around. The example happened in Botswana, for example. That is the place 60% of cervical cancer cases are living with HIV. And the National HIV Testing Organization was identified and mobilized to design and conduct the training of trainers in order to reach out to community groups, including positive women's group and all the others too, and to be prepared to get the demand raised, and also the linking up with the district medical teams and the clinics. So with all those kind of local language, local cultural appropriate communications, and linking up with the trained nurses for screening and treatment, and all those happened in a one-stop shop service providing the facilities that actually helped to both generate the demand, but also help the government to implement that see and treat policy for the 30 to 40 years old women, very, very much, I mean, towards its goal. At the very same time, on a parallel track, the country also started a 2-dosage HPV vaccination campaign covering 9 to 13 years old girls, which within 2 years, amazingly, actually almost covers that 80% of those eligible girls. I mean, all those basically are happening based on the 3 common lessons. Number one is the initial partner support, for which we refer to the George W. Bush Pink Ribbon, Red Ribbon Initiative, PEPFAR, GPAGO, Merck, and many others. And second is the government leadership and commitment. And the third, eventually, is the community engagement, echoes with this health system adjustment, with the task shifting and the task sharing. So in that way to move these things. On the applying on the inequality line, I think it's a good reminder for all of us that reaching the first behind first is a total spirit of universal health coverage. So beyond that, all those kind of great, enormous technical guidelines developed by all partners on the different particular groups of who likely would be left behind on HIV services, the community group also being nurtured and empowered to do the work. I think that really can help to identify where the gaps are, focus on how to overcome the barrier and deliver the services. On measuring the result, I think, well, there is a need, and AIDS response has proved that if you establish a multi-dimension, multi-stakeholder monitoring mechanism, which are transparent and institutionalized based on largely the national health system, that can help the things work. And in those regard, I mean, the National Composite of Policy Index, HIV reporting is using, are eventually measuring already of cervical cancer, mental health, cardiovascular disease policy level. More will be done on how to measure the service coverage. I think those three things are the things we can offer for the moment. Over to you, Emily. Thank you.
Thank you very much, Dr. Sun. So I think we've had a very stimulating and very challenging set of presentations with some direction to the future. It's wonderful to hear what different sectors and stakeholders have been thinking about, but we do now have time to take some questions from the audience. And I really invite folks who are listening to put some of their questions into the chat, because we will try to answer them. We do have time for that. And then after this, we will be having a panel discussion. So the first sets of questions come from two different audience members, and they are on the topic of the overlap between diabetes, hyperglycemia, and HIV. So James Elliott asked us about the global burden of the overlap of HIV and diabetes. And Prof. Zulke put an answer into the chat, but I think I'll open to her to share that with everyone because they may not be following the chat. But I will also, if it's all right, add a linked question, which is about Dolutegravir, which many of you will know is an integrase inhibitor, one of the more recent antiretrovirals to be rolled out across the globe. It's very efficacious for treating the virus, and it currently has a very favorable resistance mutation pattern, so that it's a really wonderful, and it's integrated into a single tablet. However, it has been linked to weight gain, and our questioner, Nongabisa Makabela, wonders about any recent discoveries linking Dolutegravir to hyperglycemia and/or diabetes, in addition to obesity. He mentions that he's had clients who have been switched from efavirenz to Dolutegravir and now present with either new onset diabetes or diabetes ketoacidosis. And so wondering what guidance there is for how to manage this difficult set of side effects. So for that question, I'd like to hand over to Prof. Zulke.
Great, thank you very much, Emily, and thank you for those questions. And I've really enjoyed every aspect of the webinar thus far. I have posted in the chat, these are the numbers from the IHME. So this is the International Health Metrics from Seattle that seem to suggest that at the moment there are around 40 million, 36.7 at the last estimate, people living with HIV, and then the proportion of those, and here we're looking just at adults that also have diabetes, seem to be somewhere around 10%. It was interesting while I was reviewing this quickly, in some low and middle income countries is up to 20%. This was from a paper from the Cameroon. So I think this is obviously something that is difficult to answer if one is not doing screening. And so one of the things I think that we're taking from this is that screening for diabetes in patients living with HIV should be an intrinsic component and speaks to that integrated diagnostic and clinical care program. I think even more so with the issues of Dolutegravir that you and Nongabisa raised. It's critically important because the data is rapidly accumulating to show that it is associated, as you say, not only with weight gain, with diabetes and other metabolic abnormalities. One is always in a balance between trying to suppress the viral load and now these new cardiometabolic side effects that are emerging. So again, here I would say the process would be to highlight the importance of screening in the population, of integrating diabetes, hypertension, and other cardiometabolic illnesses at the time of HIV screening, HIV treatment, to be able to highlight these and deal with them as early as possible. Thank you, Emily. Back to you.
Thank you. Thank you very much. And that is definitely the Dolutegravir question, I think, is one that we really need to keep an eye on going forward, especially around cardiometabolic potential side effects. So the next question is also from Nongabisa Makabela, who is practicing in Eswatini and has a question about supply chain of pharmaceuticals within Africa and sub-Saharan Africa. They note that the Eswatini is currently in the process of decentralizing and integrating NCD management with the strategy of trying to piggyback on a very strong HIV ART program. But one of the biggest bottlenecks that they face is inadequate and inconstant supply of NCD medication. So they're wondering how others have been combating this issue. And I think I'd ask Dr. Saleh to take a first stab at this question. Please, thank you.
Yeah. Can you see me? I think that's the question. No, I can't. Okay. Okay, so definitely supply chain, there has been one of the successes that we build on in HIV in general is the supply chain capabilities. I think there has been a lot of progress on that, and that was one of the key determinant factor in the success to decrease the burden. And I do acknowledge that one of the things we're looking at as we're working on the research paper with the NCD Alliance, one of the aspects is that what supply chain capabilities we can leverage to solve this problem for NCD, and it's across the board. So it is a problem we're aware of. We're looking into ways and means. There's not going to be like a silver bullet to kind of like solve it, but definitely we can draw on some of the supply chain successes and the lessons learned from HIV to incorporate into the NCD supply chain. It's not like a solution, but it's more of there's a recognition of the fact that we need to do something similar to what we have in the HIV, which is, I would say, it's even some of the successes like, kind of like the cold chain capabilities and all that, which is not an issue in NCD. So I would in NCD medications, I would think that the NCD theoretically supply chain would be simpler, given some of the kind of technicalities in HIV medication, but definitely we need to really map out how a successful supply chain would look like for NCD oral medication specifically.
Thank you. And if I may ask a follow-up on that, I was impressed in your remarks about the commitment to solidarity of Viatris. But key, as you know, to the success of HIV treatment over the last 15 years was actually when patent protections went off of antiretrovirals. And that really allowed the rest of the world to start to produce the quantities of antiretrovirals necessary. And it's been striking and disturbing to see what's been going on with the COVID vaccine, such a wonderful set of scientific advances, but such a very disgraceful, frankly, performance in terms of health equity. We're now sitting with, I understand, 3 billion people vaccinated in the world, but here in Africa, across the continent, it's less than 2%, and too many of those are contributed by South Africa, which, as you know, is a middle-income country that has purchased at their own expense most of those vaccines. So what's the solution here? And I mean, even in the United States, insulin itself has become unaffordable for so many people. How can the private sector really address this problem?
So We have a precedent in Viatris by supplying, really doing aggressive cost reduction when it comes to some of the HIV medications. So I'm not sure the COVID vaccine is there yet because it's still under intellectual property and there, but definitely in Viatris, where the opportunity presents itself specifically for low middle income countries, we definitely seize the moment. And we have multiple partnerships that we have done over the years where we really supplied HIV medication at no incremental cost, and actually at lesser cost than some of the prices that's out there. So I would say cost is one element of the equation, but definitely the innovation that goes with the COVID vaccines is another element that we need also to take into account. If it wasn't for, and again, I'm not, that also strikes very hard into the equity space. So it's actually something that I think these are early days for the COVID vaccine, I would say, but I think, and there has been efforts by organizations that produce COVID vaccine to reach out to low middle income countries in Africa in particular. And I think that effort is still in infancy, but if we look at the model of the HIV, actually led by Viatris, we can definitely find examples to follow for other companies to reach the underserved population. So it's still early days, just to summarize, still early days for COVID vaccine, but I believe the healthcare community and the private sector will come to a stage where we're going to be able to reach the successes and the reach that we have done in HIV.
Okay, thank you. Now, Dr. Ferris and Dr. Gangsun also have some comments on the supply chain issues. I'd like to open up briefly to each of them. First, Dr. Ferris, and then Dr. Gangsun, just to put those into the conversation.
Absolutely, and thank you very much. It's, supply chain is quite complex, and particularly now given some of the interruptions in supply chains, but particularly for non-communicable diseases, there are a lot of opportunities for local and regional productions and ways to kind of make your supply chain more resilient. I did put a quick link in the chat to a document that an article that came out supported by PEPFAR, really kind of looking at these questions. And I'll put another link to the supplement that article was in. Again, looking at how to leverage the HIV platforms to better deliver services for non-communicable diseases. I think this audience would be particularly interested if they haven't seen that supplement already. Thank you.
Thank you. And Dr. Gangsun?
Yeah, maybe just very quickly, I think supply chain management has been a chronic, I wouldn't say a barrier, but sometimes a difficult things that cross many countries that for HIV and other services, I think the case of NCDs can be imagined. So of course, there are many investors goes into this kind of system building. But in many cases, I think what the focus should also be transferring the capacity to the local, the arrangement, to the local staff member, and then to get every single step addressed. Not only something like stock management, it's starting from forecasting. I mean, even before forecasting, that linking with the treatment guideline, which is the forecasting, and then the procurement processing, and the payment in many cases are holding many countries back due to the very small errors which could be avoided. But then the other element I'm trying to emphasize would be accountability, which will be every single person in the system has to play their role very, very seriously. And in addition to the classic system, I think more and more people are also seeing community themselves could actually be the ones to actively get into contributing on how to improve accountability. With a simple thing is to report the either perceived or actual stock out, and then alert the authority and the system to look into what exactly the problem and how to solve it. There are also the guidelines on community-led monitoring, for which I'm going to share in the chat box. Thank you.
Thank you so much. And you've led us very well into the question that I'm now going to ask all of our panelists to provide us with brief 2-minute comments on, which is really, as you were just highlighting, what opportunities do each of you see for for the different sectors and stakeholders to now work together on this knotty problem that we've been discussing in the countdown to the SDGs in order to make the kind of integration that I think we all agree is ideal actually become a reality. And I will start, I may add two sub-questions if you wish to address them. The first one is, I think one of the challenges in non-communicable diseases, I mean, we've heard really compelling stories even today mentioned about cervical cancer, mental health, cardiovascular disease, metabolic diseases. But as the clinicians among us know, each of these has wildly different clinical needs. And when we speak about NCDs, I mean, I think, if I can editorialize for a second, that part of the success of PEPFAR was its focus. And so one question would be, in this, how can we kind of focus our next efforts to achieve this integration of care? And a final question, if you feel like answering it, one, what can the academic sector do? I just asked that personally as a member of that sector. So you can speak to each other, what you'd like to see other sectors do, how we can integrate, and what remaining questions really need to be addressed by the academic sector. So let's start with Ms. Muturi. I would love to hear your perspective on this. Muturi, I'm sorry for mispronouncing. Ms. Muturi from Kenya.
Okay, thank you for that. I think in terms of the opportunities that I see, I think for me, the biggest example in the issue of inclusion, because as you heard from my presentation, we are very big on inclusion. And I think for multilaterals, especially, whether it's the UN, WHO, African Union, setting strong examples of inclusion at that level would be a very bold statement to, whether it's national or county governments. So for me, I would say setting a strong example by multilaterals is the biggest thing for me. In terms of the different clinical needs that we have, that is true. And I think even within mental health alone, we have so many, different diagnoses, and even just bipolar looks different in 3 people. But what we did, like when we had an opportunity to have our own presentation in the National Task Force on Mental Health, we sat down as 15 persons living with mental health conditions around across different conditions, and we came up with like 6 main areas. So there was stigma that was for all of us, and I think that also works for HIV. There was access to healthcare, that is finding affordable, accessible, available, and acceptable services. That was common for all of us. Then there was education, reasonable accommodations. In education, for example, like in our support groups, we find most people finish degrees within 8 to 12 years, and some universities, don't allow that long. So we have people who have like 3 units remaining and they can't graduate. But then it's a common challenge, because even persons living with cancer during chemo times, would have delays, or for persons going through dialysis, say 3 days a week, and the days between they feel weak. And so that's a common challenge across. And reasonable accommodations in employment, like personally, because I am on 1st generation and 2nd generation drugs. 1st generation is the bad quality that most of you have banned in your countries, and 2nd generation is the better one. But because I am not in employment, it means I have to sort of find a balance, and there's a price to pay, because the medicines make me foggy in the morning, so I'm not really able to be sharp before 10 a.m. And it's the same thing for that person going through dialysis. They will need reasonable accommodations in employment. And lastly, for all of us, social protection, because NCDs are both a cause and effect for poverty. It's like a never-ending cycle. And like in my country, social protection is there for children, persons with disabilities, and elderly. For persons with disabilities, we qualify as persons with mental health conditions under the UN Convention of the Rights of Persons with Disabilities. But people with physical disabilities have not embraced us. So I think that's how I would answer that question, that there are common threads across both communicable and non-communicable diseases that we can address. Thank you.
Thank you so much. That's really insightful and gives us a strong call for a way forward, looking for commonality both between non-communicable diseases and between non-communicable and communicable diseases, and always centering the patient's needs at the center of our work. Next, I'd like to ask Dr. Ichapuria to respond to the panel question.
Well, I think that we have a real opportunity, to build back better from COVID. We have a chance to rethink our approach to digital transformation and of healthcare. And I really do think that technology-powered care systems offer us an opportunity to move healthcare from episodic and siloed to continuous and integrated care. I know that incredible efforts are also happening in the frugal innovation across low and middle income countries, and we need to sort of capitalize on those. We have to link up, learn from each other, build sustainable health systems that are built for the future. I mean, the type of innovative efforts is pivotal to achieving the sustainable development goals, and doing so in an integrated way, as we've sort of discussed today. But I do think that we have to, I'm glad we're having this conversation. I think that non-communicable diseases are very important. I think we need to look for all of those intersections. We need to continue the collaboration we're doing. But I also think we need to think about innovation. Innovation is extremely important. And I think that's the only way we're going to scale this huge problem, is a way, as such as our NCD Academy. Because of the e-platform, we were able to teach a lot of people very quickly. That was an innovative solution. So I think looking for innovative solutions to scale a large problem.
Thank you. That is also very inspiring and actually also practical, which is helpful, especially when thinking about this very large and complex problem. Dr. Ferris, I would love to hear how PEPFAR is planning on maintaining that wonderful focus, but also expanding into all of the different realms that you discussed.
Thank you. Yes, and that is the day-to-day discussions, is how do we stay laser focused on viral suppression, epidemic control, and HIV, while addressing the issues that clients are facing. And again, coming back to client-centered design, I think that is going to be a guiding light for us. Again, encouraging people who haven't already to make comments on the Vision 2025, which included significant consultations with advocacy groups. So within PEPFAR, those are definitely things that we are looking to do as we continue to roll out and march towards our focused epidemic control goals. I think second, though, beyond PEPFAR, USAID is looking at our global health portfolio and seeing how we can better integrate and leverages the advances that have occurred across our health assets. That includes the supply chain, which the strides we've made in HIV expand to the other initiatives like PMI, the malaria initiative, building robust health systems, maternal child health programs. So those are all opportunities, and we see the movement happening not just within the US government, but like Dr. Ren Mungui has just convened the strategies for their Department of HIV, hepatitis, and STIs, and kind of integrating strategies there. You also know the work for PEPFAR in terms of cervical cancer and mental health. These are all things that are high on the agenda. And I will drop another link in the chat to kind of, it's another wonderful resource to see how this is coming together. And the time to refocus is now. So thank you.
Thank you very much. Dr. Salam, your response to how we can best integrate the sectors together to achieve this ambitious goals.
Yeah, thank you. One of the things I think we have been doing very well, with all our partners, but I would like specifically to highlight our partnership with the NCD Alliance and American College of Cardiology with the private sector in general, is having a common vision, common agenda with trust and transparency. So there are no good guy, bad guy here. It's like we are working together towards a common goal. And that really helps because we really, as a team, we really look into the solutions, and we're like, each one of us does definitely their part, but that is trust and transparency is key for what we do. So this is key for integrating the private sector in any multi-stakeholder collaboration. I put 10 points on that. Other from our experience also, and we heard it today, inclusion of patient voice. The patient has to be part of the solution, and this is why I discussed the surveys we've done. I've discussed we heard about our views, our voices with the NCD Alliance. So the patient voice, and because the patient empowerment is key actually when it comes to those providing those solutions. I think the local knowledge is the third point I want to highlight, is the local knowledge. While the problem can be, looked at at a macro level, really the solutions are very local. So you need to understand, you need to have this local expertise to understand what is the root cause of the problem that you want to solve for. And if I give just examples on the NCD, for example, in Europe, the NCD problem is mainly due to all the adherence. In Japan, we're talking about aging population, whereas in emerging markets, it's mainly cardiovascular diseases and adhering to guidelines and the need for policies. So again, I'm providing a rather broad brush, but again, really looking into those types of archetypes with the leveraging the local knowledge in order to bring solutions, practical solutions, and relevant solutions to the communities we serve. And stop me when the time comes, but the political willpower is important too. So I will stop here, but it's just, I want to highlight that the political willpower really helped us when we had this NCD on the agenda, really helped us to, from a local perspective, to really push the NCD agenda forward.
I totally agree. Thank you. Dr. Sun, your final remarks on opportunities for integration between sectors.
Yeah, many thanks for giving me this the opportunity. I would think of probably from utilizing the existing partners to utilizing the existing mechanism, and then to use or build up innovations would be opportunities forward. Let me first pick up on what Clarity started. I think while in addition to many partners, of course, we also enjoyed a lot of collaboration with NCD Alliance and many other partners. Since we are as part of the UN General Assembly side event, make the UN or the multilaterals to the extent possible. There has been since 2013, the UN Economic and Social Council, ECOSOC, established that UN Interagency Task Force on Prevention and Control of NCDs. It got all the major UN agencies there with a mandate from let's say, UNDP considers NCD as a development issue, to, of course, WHO of everything, on health. They are taking the lead. And also with UNICEF considering age of opportunity of focusing the adolescent, young people, children, and productive age women as the opportunity to prevent and to build up the solid base of combating, not only preventing, but also even to control the NCDs, to the UNFPA, IOM, which are also largely addressing gender-based violence, sexual reproductive health needs of people, and mental health to the extent possible. Beyond that, there is also this kind of platform called Global Action Plan for SDG 3, which is comprised by all the major, so to speak, international health organizations, including the Global Fund and so on. So that is also a kind of mechanism that can eventually not only provide technical guidance, the normative guide, but also programs that the pilot, the things, the good seed that can grow into a big plant.
Thank you.
Yes, it's my time off.
I'm sorry. I'm sorry. We have just 2 minutes, and I just don't want to let the session end without thanking all of our esteemed keynote speakers and panelists. This has been an incredibly stimulating, challenging, and inspiring discussion today. Thank you to the NCD Alliance. Thank you to Viatris. Thank you to the American College of Cardiology. I was going to make a couple of remarks based on our own research, but I think I'll have to leave that in the interest of time. But I will just mention that one thing that became very clear to us from a population health perspective was that actually in our setting, where HIV is such a massive problem, more people had NCDs who were HIV negative, but households are mixed. So I just put an appeal out that we take a full population and public health approach to this problem, not just an individual health approach. So even as we think about people with HIV, we think about their family members, their mothers, their fathers, and their children. And that we try to come up with clear and integrated frameworks so that we can express our goals clearly. As Dr. Salas says, we need to have more clarity, I think, in this important topic so that we can drive towards our common goals. But the summary messages have come through very clearly. We have an imperative to build back better from the COVID-19 pandemic. We have to always keep equity, health equity at the forefront. We need to always involve patients in affected communities. We must think very carefully about the role of innovation, digital health, but we must also try to take the important things that we have developed some solutions to, like supply chain, and rapidly expand them to additional diseases. We need to always let our messages be based on local knowledge, expertise, and to be integrated into local health systems. And finally, we call on the United Nations, all member states, because the political willpower is absolutely required if we are to realize what we need to do in integrating the non-communicable diseases and HIV care with the promise that has been painted for you today. Thank you very much for attending this session. Thank you to the organizers, the speakers, and the panelists, and we look forward to continuing this conversation in social media and in the venues that you've been pointed to. Thank you, everyone.
Thank you so much.